Hi again, everyone. I'm Chuck Neff. Welcome to today's program. We're going to talk about durable medical equipment and prosthetics. By the way, this program comes to you live from the EES Broadcast Center in St. Louis, Missouri. And in addition, for your convenience, the program is available to you in closed caption. And at the end of the program, please remember to complete the combined registration and evaluation form, and also include any suggestions you might have for future topics. Our phone lines will be open at the end of our speakers' presentations for any of your questions or comments. The number to call when we open the lines, 314-894-5734. So let's say hello to our speakers, and back with us once again, Laurice Himes. Laurice is a veteran of this programming, having presented multiple times in the past couple of years. She has 17 years of experience working as a medical coder, compliance coordinator, auditor, physician educator, and supervisor. And just recently, she accepted the position as the HIMSS chief at Dorn VA Medical Center in Columbia, South Carolina. Congratulations. Thank you. Laurice has an associate degree in biological and behavioral sciences. She holds a HEMA certified coding specialist and AAPC certified professional coder credentials. And in addition, Laurice is a HEMA approved ICD-10 CMPCS trainer. And lastly, Laurice has been a VHA Coding Council member since 2005. Also joining us today, Tamara Newberry. Tamara currently works at the Sierra VA Medical Center in Reno, Nevada. She's a certified prosthetist and orthotist. Tamara has worked in the prosthetics and orthotics field for 20 years, graduated from the Pittsburgh Institute of Technology, and is certified by the American Board of Certification in Prosthetics and Orthotics. Welcome to both of you. Good to have you with us. Laurice, we're going to start today with you. Welcome.
Good afternoon, everybody. Welcome to the ABCs of DME's Prosthetic Coding Program. Today we're going to become more familiar with the history of prosthetics and DME usage. We're going to understand the VA coding process and look at the common prosthetics used. Then we'll hear from Tamara Newberry, and we're going to see how clinicians determine the correct prosthetic for a patient. Let's look at the history of prosthetics. Notice from the picture, there's a gentleman who, after becoming injured and requiring 2 prostheses, evolving with every step he's taking. This is how prosthetics have evolved, becoming more and more finessed and technologically advanced. Egyptians are touted for the invention of many things that we still use today, and the use of prosthetics is just one mention. Prosthetics were used for a sense of wholeness and appearance versus functionality. In 1945, the National Academy of Sciences established the Artificial Limb Program. The Veterans Administration is one of the largest healthcare providers that have a dedicated prosthetics program. We also have a very large patient population that relies on prosthetics and orthotics to restore their physical function. Here is some history of prosthetics use in the VA. In 1948, the Prosthetics and Sensory Aids Service, known as P&SAS, was founded. It is currently the largest and most comprehensive provider of prosthetic devices and sensory aids in the world. In 1956, Congress passed legislation to start up the VA Prosthetics Center to serve our amputees from the World War II. The VA is also responsible, in conjunction with the Northwestern University, for the electric elbow. Lastly, the VA has developed many cutting-edge prostheses, such as the Generation 2 DECA arm, to care for our veterans who have lost physical function. Let's take a look at a video that shows a veteran being fitted for a knee prosthesis.
Some 42 years ago, John lost his leg above the knee. It happened during a mortar attack in Vietnam. Since then, he's had to wear a prosthetic knee. And now, thanks to VA, he's being fitted for one of the most advanced prosthetics available.
What I'm getting now is a complete new design all around, and it's a dramatic change from what I'm used to.
The new device, called the X2, comes complete with microprocessors, sensors, and even a gyroscope. It offers amputees like John more freedom of movement enhanced balance, and a better life.
Traditionally, amputees will bear all of their weight through their good leg, and it begins to fatigue and tire. With the new prosthesis, the programming allows him to shift, and the knee automatically locks at a flexed position. It's kind of what we do normally.
First, it was necessary to determine specifically what steps John would need to take in making his transition to the X2. So, VA performed what's called a gait analysis. The study was videotaped and showed that he would have to make some changes in the way he moved.
And it's difficult to walk the way that they want me to walk.
Adapting to this new device, John is being helped by VA physical therapist Lindsay Martin, who's been working with him at the Walter Reed Army Medical Center in Washington, D.C.
It's a great partnership already. I mean, she's enthusiastic, she's encouraging, patient. You know, it was a good match right away.
Good.
And I tried it with the newer device, and it's a lot easier.
Along with its other benefits, the X2 is smaller, lighter, and has a longer lasting battery than John's older prosthesis.
We are so very proud to be able to restore physical function to our wounded warriors who serve our country. Let's move on. Stents, replacement joints, ocular lenses, oxygen, therapeutic support stockings. These are just a few samples of the prosthesis provided to our veterans. Let's take a look at some of the devices dispensed daily to our veterans. We have things like hearing aids, contact lenses, speech devices. These are considered sensory neural aids since they enhance the sensory organs like the ears and eyes. Medical equipment devices are those that enhance a patient's body function or increase safety while the patient maintains independence. Crutches, monitoring devices, and items like patient lifts help the patient remain safe in his home. Large items like hospital beds allow the patient to remain in their home environment and receive home health care. Here are some terms used in relation to prosthetics or orthotics. DME, or durable medical equipment, are items used by the patient in his home and private life that improves normal function. These types of equipment are those that are external to the patient's body and can be used repeatedly. Here are some examples like oxygen tanks and diabetic socks. Implantable items are items that are left in the patient's body during a surgery or a procedure. Some examples are cardiac or vascular stents or intraocular lenses. Let's talk about the HIMSS coding process. It is widely recommended that HIMSS work from an Excel spreadsheet that is sent from billing with the prosthetics and orthotics identified that were dispensed or mailed out to the patient. This spreadsheet is to be used as a work list only. HIMSS will create non-count encounters to capture all of the items on the spreadsheet, validating what is in CPRS and what is in the 2319, known as the prosthetic screen, in VISTA. Continuing with the suggested coding flow process, once these encounters have been coded, HIMSS will communicate with billing so that they may bill the encounters. Once filed to PCE, these encounters will appear on the Bill Me as well. Service-connected and special authority encounters should not appear on this spreadsheet. As we know, service-connected, and special authority encounters are not billable. In order to code prosthetic encounters, the coder needs to verify the provider. Nurses, respiratory techs, etc. cannot order prosthetics. The ordering provider must be an MD, NP, or PA. The ordering provider cannot, if the ordering provider is not located in CPRS in the consult tab, then you may look in the E&M note that precipitated the need for ordering the item. If the ordering provider information is not available, it is permissible to use the patient's primary care provider. I mentioned this in a few slides earlier, but I'd like to reiterate that these clinics are non-count and all items should be verified in the prosthetic screen 2319 to ensure the items have not been previously captured and that all of the items have been sent on that spreadsheet. If there is a discrepancy, enter what has been verified from the 2319 and what has actually been delivered or dispensed to the patient from CPRS. The next few slides are screenshots of what you'd see when creating the encounters. Here, we should make sure that we have the date the patient received or picked up the item. For surgical implants, this would be the surgery date or the procedure date. Next, select the correct location and visit type as specified by your facility. Of note, the visit type should be ambulatory. Items received while the patient is an inpatient will not be separately captured as it is included in the DRG or diagnostic related group. Add the diagnosis, the HCPCS code, and provider information as listed on the spreadsheet and after verification of the 2319 and CPRS as needed. The encounter may then be filed to PCE. Let's go into depth with how we would find the diagnosis. We would look in CPRS tab for specific information related to the prosthetic. Here's an example of how one may look in the Consult tab. Notice the diagnosis presbyopia would be our diagnosis, and this is the reason why the patient received the eyeglasses. There are many patients who receive oxygen on a routine basis. There must be a prescription for oxygen before it can be dispensed to the patient. This information could be located in Vista Imaging as a scanned document or as specified by your facility's HIM department. The biggest crux to coding these encounters is verifying that the item has a current prescription and that the item has been received by the patient. It is recommended that HIMS and the prosthetics department work together for the best process to code these encounters. Even though the spreadsheet will have the HCPCS codes listed, verify that the codes are correct. The dispensing units are correct per the HCPCS code book and that the codes are even still valid. Coders will add certain modifiers to these encounters based on the type of encounters. Some common modifiers based on the item dispensed to the patient include NU, CPAP supplies, RR, wound vac, LTRT for the anatomic distinction. Please coordinate with your HIMS and your facility billing department to determine if modifiers need to be added. Let's look at some of the items that may be coded as rental equipment. Wound vacs, wheelchairs, home oxygen, as well as beds are the more common items. Remember to add the to and from date in the case comments when the time period is less than 30 days. Again, we'd like to stress the use of verifying the item, the quantity, in the 2319 prosthetic menu, and also coordinating with the HCPCS book. A big reason is that an item may have been described as a pair of diabetic shoes on the spreadsheet, but per the HCPCS book, diabetic shoes as well as socks are dispensed per 1 unit. Shoes, in our example, the unit for a pair of those would be times 2, since 2 were dispensed. We've already talked about coding oxygen tank encounters, so it is fitting to give the rules for coding these encounters. Oxygen encounters are coded per month, per each patient. A new prescription is required annually, and as we discussed, oxygen is prescribed through prosthetics as well as dispensed through prosthetics. Rental items like oxygen, beds, etc. are coded per a 30-day period, and as we said earlier, inpatient items are not captured in PCE. They are included in the DRG. Here is an example of how we would capture implanted prosthetics. The patient is having a cataract extraction with subsequent posterior lens insertion. We would code the CPT code for the procedure and then add V2632 for the PCIOL. The anatomic modifier we talked about briefly on a previous slide would go on the CPT code. In this example, the patient had a pacemaker generator inserted with dual lead insertion. We would capture the CPT code for the generator, the leads insertion, and then we would add the HCPCS device codes C1785, C779 times 2, and then we would have a unit of 2 for the leads, as the description is in HCPCS book is for 1 lead. Next, we will be enlightened by Tamara Newberry, a certified prosthetist orthotist with the Sierra VA Medical Center in Reno, Nevada. We will learn about the clinician's process to determine the correct prosthesis for the patient. So take it away, Tamara.
Thank you, Larice. I'm glad to be here to share some of the duties and knowledge skills for the VA prosthetist orthotist. I won't go over all, but some key knowledge, skills, and abilities would be to have the knowledge of the current device technology, knowing measurements, casting, and scanning techniques. The patient's activity level is the first determining factor in choosing the appropriate componentry for the fabrication of the prosthesis. Examples of each of the function levels. And as you note in the function levels, it does say that the patient has the ability or the potential to do the activities. So in a K level 0, this patient has is not a candidate for a leg because they are either too weak to stand or they have too many comorbidities that would not enable them to be able to utilize the prosthesis. The patient can utilize a prosthesis in a K level 1 for independence and transfers for safety and or to just walk short distances at 1 speed, typically called a community ambulator. These patients tend to utilize a wheelchair when leaving their home. A K level 2 is a community ambulator, which means that the patient is capable of going out of the home, usually with a walker for assistance. This patient walks only at 1 pace as well. A K level 3 patient can vary the speeds with the changes in the terrain, conditions, and barriers. A K level 4 is a high impact patient who either needs to have a higher level activity prosthesis because of their job or maybe an active child. Types of feet and knees function appropriately for the different function levels. A K1 is a stable and safe component, and the features of those help the balance and the safety. K2 knees and feet allow stability and are lightweight with some energy return to assist the patients in walking longer distances. K3 knees and feet are designed to allow the patients to continue everyday normal activities and are durable and withstand higher levels of activities. K level 4 patients don't get anything special. They can have anything that a K level 1 through 3 can have. When choosing an appropriate component, such as a prosthetic foot, many factors may be considered. The weight of the foot, because all the feet have limits, so the weight of the patient determines which feet that they can have. This is associated also with the warranty for the item. Correct component to fit the design of the prosthesis. Stability and balance is the key to an amputee attaining the maximum activity level possible. If the capability of the foot does not match the potential of the patient, balance is impossible. I'll turn the program back over to Larice now.
Thank you, Tamara. That was very informative. I'm sure most of us have not been exposed to the insider's view of prosthetics like this. So hearing firsthand the clinical side, we can only improve our coding knowledge, in my opinion. So let's wrap up our presentation. And here we have some summary points. Prosthetics are used to restore function and appearance. We've come a long way from the practice of the ancient Egyptians. Coding prosthetics require the coder to verify and locate specific documentation. It is recommended that HIMSS works with their facility's CPAC or billing department for the best practice. We also learned that clinicians assess patients' activity levels to select the correct device. These are just some of the references we use to develop the content for this program. Continuing education, we're pleased to inform that AAPC CEUs are available. Note the AAPC index number for your records. You could also self-report 1 hour of education in VA-TMS and to AHIMA. As always, feel free to contact either Tamara or myself with any questions. Our email addresses are listed here. Now we'll turn the program over to Chuck to take your questions.
All right, Larice, Tamara, thank you very much. We'll go ahead and open up our phone lines. If you would like to join us on the program today, any questions, any comments, there's your phone number, 314-894-5734, 314-894-5734. While we wait a few minutes to see if any of our listeners want to join us. Tamara, let me come back to you. Tell us a little bit. Welcome, by the way, first time here on the program. Good to have you with us today. Tell us a little bit about your background. How did you get started in this?
My second husband was an amputee, and I went to his appointments with him, and I was encouraged by his prosthetist to pursue the business.
And so you did.
And so I did.
Yeah, and 20 years?
Yes.
Wow. Wow. Tell us exactly what it is you do day to day.
Day to day. At the VA Center, I go to amputee clinic once a month, and I help the physicians and the physical therapists determine the activity levels that we talked about earlier so that we can make sure that the patients all get appropriate devices.
And I'm going to presume that in 20 years of doing this, you've seen the changes in how patients are being treated. Can you give us some sense of the advances that you've been able to see in 20 years?
The advancement of the microprocessor knees came through after I got certified, and I've seen a lot of upper extremity changes with the hands that move with the fingers independently. But I've also made a wooden leg in my career, so
Really?
I started out old school.
Okay, and then I mean, you just have to presume that Tamara was talking early on in terms of the advances in the technology and really, reaching out to help patients who need this kind of help. Have you seen, can I call them miracles in terms of how people react to what you've been able to provide for them? Yes,
it gives them back their dignity and their function, and they can go on with their lives. So that's the main focus.
And then I presume that has to be quite satisfying.
It's a miracle every day.
Nice. 314-894-5734 is our phone number if you'd like to join us. Any questions for Tamara or Larice today? And we talk about the advances, but what are the challenges that you face in helping your patients today?
We have to deal with their comorbidities as well, the other diagnoses that they have. It's a lot of encouragement. We have started an amputee support group at our VA center, which is really helping the new amputees. They get together and talk and encourage one another. So
yeah, I'm always amazed that when we take time to encourage somebody else finds a little bit of hope in whatever they're dealing with. And I presume you have to see that on a regular basis.
I see that every day, every day. I revel in people's accomplishments, and I try to assist the ones who aren't there yet.
We were talking a little bit before we went on the air today about one of the questions I want to ask you, and you said this is going to take 3 hours. Well, we don't have 3 hours today, but I still think it's a good question. Give us some sense from your perspective. What's involved in creating a prosthetic for one of your patients?
The first determining factor is making sure that the components as we talked about today, that they're correct for the patient as far as their activity levels. We don't want to put a foot that somebody could run on an 80-year-old guy that sits in a wheelchair most of the day, because it would create a prosthesis that was too heavy and probably be a deterrent to his activity. And so you make your choices as far as the prosthetic components are concerned, and then we take an impression or a scan with a CAD/CAM unit and have a socket made, make sure that that fits correctly, and then we put the leg together and let them practice before it's finished.
So a lot of nuances in how you treat your patients.
Yes, yes. It's a lot of patience. You have to teach the patients to have patience.
314-894-5734. That's our phone number if you'd like to join us on the program today. And Tamara, one more question as we're talking about this in terms of looking ahead. Where do you see, can you crystal ball for us a little bit in terms of where you're seeing this going?
There's a lot of changes in the VA center where I'm at. We're expanding our prosthetic department, and I think we'll be doing more stuff in-house, which is going to, make sure that our coders know how to code the stuff when it goes out. I think they do that at a lot of the VAs now, but where I'm at right now, we're growing that. So that's where I see my VA going.
Yeah. And Laurice, let me pull you back into the conversation here. We talk about the coders getting involved. Explain to us, certainly they've got to be working together in terms of everything that's going on, trying to help the patients, but coding all of this. Besides the documentation, which we know is so critical to everything, what else can those in our listening audience or viewing audience today, what can they do to help in this process?
What they can do, as I probably over-suggested, is to coordinate verifying all of the data by using the Vista Screen 2319, and also verifying your HCPCS codes in the book, because sometimes the spreadsheet may have codes that are outdated or maybe a typo. And if you see anything that doesn't quite fit a description in a HCPCS book, you may do some research. You may Google some of this information to find out what are the suggested codes that you may use. But the biggest thing is to make sure that we capture all of the devices that are dispensed or picked up to the patient. And make sure that when we read our op notes or our procedure notes, that what we're coding for is actually what was implanted in the patient. Because sometimes, as we know, there are several codes for one device, but each code describes a different component or nuance of that implanted device.
And working together, that's so important, isn't it?
Yes.
Yes.
Yeah. You see that too, Tamara?
Yes, I do. I do. I think that the practitioners should also know about part of the coding process, which is what I did in my previous position. I was a compliance officer, and following the codes and the guidelines for the third-party billing, things have to be right. The activity levels have to coincide. The activity level for the patient has to coincide with the components that you put on there, or it just doesn't get accepted.
314-894-5734. That's our phone number if you'd like to join us. Let's take a phone call from Salisbury, North Carolina. Thank you for joining us. Nice to have you on the program today.
Thank you. I appreciate it. This question is for Lori, please. In creating the prosthetic encounter, the date the patient actually received the item is kind of unclear to us at times. As in slide 15, it states to go by the delivery date. However, that is not always the date the patient actually received the item. Here, it's usually the date that the visa is actually charged for the item here in the prosthetics department. Do you have any suggestions as to how we could easily find a delivery date, or do y'all have any examples in place as to, what would be the best way to figure that out so the actual date of service is correct?
Yes, this is really a common concern, the delivery date. It's best to look sometimes in CPRS when in the consult tab when it's closed out, if there isn't a date there to describe when the patient actually received the device or when the device was delivered, it would be a good practice to maybe suggest that that information is put there, because it's not the date that it was ordered, it's the date that the patient received it via procedure, surgery, or had it delivered to the patient. Because as we know, things can be sent out, but it may not always be certain if the patient even received the item.
Does that help? Okay, we're going to presume that it does. Again, if you have any more questions and need some more clarification on that, the emails are listed in your handouts today. We'll take a few more minutes to see if any of you would like to join us, spend some time with Larice or Tamara. 314-894-5734, that is our phone number. Larice, this is an email that came in from the field recently. Has anyone come up with a productivity standard for prosthetics coding?
Well, determining a fair and appropriate productivity standard requires, I guess, some study of that position and then actually looking and observing to see how long it takes for the coder to actually complete an encounter. There aren't any standards for prosthetics at this time. And it requires, you know, as we know, to do prosthetics coding, it requires more than just a glance at the patient's documentation and assigning codes. You actually have to do a bit of analysis of the documentation, and as I say, coordinate between the Vista screen, your HCPCS book, and the spreadsheet, and sometimes CPRS. It's suggested that, you know, facilities do a study on productivity for their coders at their facility to start the study and share the statistics with other HIMSS departments so that eventually those that have the high volume of prosthetic coding can share that data, and then we come up with some good standards. This is also a good topic for the HIM Field Leadership Council to consider.
Sharing the data, that's interesting. That's a nice clarification to be able to share what everybody's finding in their respective VA centers.
Yes, and then this is a good way to come up with productivity standards to see, you know, what's actually being performed and how long it's taken to be performed, and then, you know, just roll out some standards nationwide. But until then, the facility itself should pretty much gauge how the coder is assessing all the documentation and how long they typically take to do the encounters, and they can gauge from there what is acceptable as a productivity or not.
We'll take another minute or two and then wrap things up. 314-894-5734 if you'd like to join us on the program. As we start to wrap things up, just any final thoughts, if any one thing you'd like to communicate with our viewers today?
Well, I'd like to say, you know, I found what Tamara did to be very interesting, and it's just fascinating that, you know, we could provide, you know, a life, or, you know, or even improve our veterans' lives by just even improving their cosmetic appearance, not to even mention their physical function with the prosthetics that you devise. And I found it very interesting that the prosthetics are not totally assembled when they come over. They actually have to be assembled by yourself and other people in your department, much like doll making. Would you like to talk about that a sec?
Sometimes I'll simplify the process to a new patient by telling them it's like putting together Tinker Toys. You know, we just have to find the right ones to put together to make what you need so that you can get up and start moving as quickly as possible. And they like that analogy. Try to break things down and make it fun, you know, because it's not always a fun process, but sometimes it's about your attitude. So,
when somebody comes in and needs a prosthesis, how long does it take to
it's not really that long. It's making sure the socket fits correctly, and the rest of it goes pretty quickly because it's an endoskeletal system where you just put the pieces and parts together and make sure it's the right length. But the important part is fitting the socket and making sure it's comfortable.
Talk a little bit more. I love the word dignity that you used earlier in terms of being able to give your patients dignity in who they are as men and women. Help us understand what that really means to those you see.
Well, what I've seen in my career is, say, a 6 foot tall young man with a family and a job, and for some unknown reason they lose their leg, okay, or for whatever reason they lose it, and then all of a sudden they're sitting in a wheelchair. And where they've spent most of their life looking down at people or in their face, now they look up. To see that person get up and take their very first steps on a prosthesis, it changes their life because they know at that point life's not over. It's just going to be different. And sometimes hooking up one patient with a successful patient with a new patient so that they have a mentor makes a really, really big difference. And it gives people back their dignity.
Giving people back their dignity. Well, I think we should probably wrap it up. Great information, but to hear firsthand, as Tamara was saying, how you're dealing with, as I like to say, in the trenches here with everybody on a day-to-day basis. To hear those kinds of story, I hope and I think that probably everybody watching today is going to find a great deal of hope and satisfaction and motivation, I think, to be able to do that even better. So thank you very much for doing that. We appreciate it.
Thank you.
We will go ahead and wrap things up for today. Please remember to complete that evaluation form. We do look at it, we do need it, and please note our next broadcast, May 15th, Tiffany Ortiz will discuss documentation and coding for spinal cord injuries and treatment. Special thanks today to our speakers, Larice Himes and Tamara Newberry. Thanks also to you, our viewers, for joining us today. We do appreciate it. I'm Chuck Neff. See you next time, and make it a great day.